Welcome, everybody, to this LAX 18 Digital Conversation. I'm Davidson. March is Colon Cancer Awareness Month, and it's one of the most preventable forms of cancer if caught early. There are many ways to be checked, from at-home kits to virtual and the gold standard colonoscopy. So which one is best for you, and when should you start screening, and how often should you get it done? Joining me to answer these questions and more is Dr. John T. Dvorak. He's a colorectal specialist with Colorectal Surgical and Gastroenterology Associates here in Lexington. Doctor, welcome.
Thank you very much for having me, Dee.
Okay, let's talk a little bit about this important screening that many of us think that it's something that we do once we hit 50, but I guess if you have a family predisposition, you should get it done even earlier.
Yes, and even the American Cancer Society has now suggested 45.
Oh.
We're seeing the highest rate of colon cancer incidence of new diagnoses in those younger than 50. So the screening is moving earlier now. Screening is important, and this is March, and this is Colon Cancer Awareness Month. So let's talk a little bit about screening.
Yes.
If you're coming to see me as a patient, I think that there are options in this day and age, and specifically 3. Colonoscopy, virtual colonoscopy, and some sort of a home testing kit. Cologuard is the most popular. So I think when a patient comes to see me, we have a discussion about all 3 of these, and we discuss cost, efficacy, and quality of each one, because there are decisions to be made. We want to look at which one I favor. I'm going to come out of the box and say colonoscopy. It remains the gold standard.
Sure.
So if we're looking at a test for a screening, you want to pick up a disease early before it becomes a problem for you. And colonoscopy has proven over and over again that we can pick up polyps in the colon and remove them before they become a problem. This then allows us to prevent the ultimate development of a cancer down the road.
Right.
So colonoscopy remains the gold standard in terms of picking up polyps early and picking up cancers. It's almost 100% in picking up cancers.
Oh, yeah.
And maybe a miss rate, it's reported around 10–12% for small polyps that we might miss. So still the gold standard.
So the most important thing, though, with the colonoscopy is the prep, because the better the prep, the cleaner you are, the easier it is for you to see and detect. Right?
And that definitely comes down to quality measures. And one quality measure is having a great prep. Another quality measure is having it done by a specialist who does a lot of colonoscopy and measures his data, knows that how many polyps he detects on a regular basis. We know that the average population is going to have about 25 to 30% polyps. We should know that a endoscopist who's doing colonoscopy on a routine basis should pick up about 25 to 30% polyps. That's their rate they measure and should know. So that's a quality measure that the physician uses to measure himself or herself to make sure a good quality test is being done. Also, the exam can't be rushed. It has to be done in a way that you really get a good view of the colon. So those 3 things, a good prep, an appropriate withdrawal time, and an adenoma detection rate measurement by the physician, are important for a quality colonoscopy. And if you do that, you're going to have very low miss rate for cancers, very low miss rate for polyps.
But a lot of people are understandably afraid of going and having this done. But really, I know for my husband and my mother who've had it done, they said the worst part is really the prep.
You're right.
Yeah.
And even that we're working on.
Yeah, exactly, because the bottles are getting smaller than that you have to do. But now, once a patient comes in to get the colonoscopy, they are administered medications to help them not even really remember, right?
That's correct. Okay. It's about a 30, 35, or 40-minute test. Patients are very comfortable. There's choices of anesthetic, but mostly we just use sedation. And patients wake up and they go home after that. They can't drive that day. Right. They can't make important decisions that day, but the next day they're back to work.
Right.
Okay. So that's colonoscopy. Right. But if you're really resistant, you're in my office and you're like, I don't want colonoscopy. I would rather you get screened, I don't care how, than to go unscreened, because this is such an important health issue. So then there are other tests that can be done too. There's virtual colonoscopy.
Let's talk about that.
Virtual colonoscopy is a test where you would take a bowel prep, so you need to be cleaned out.
Right.
You go to a radiology suite, and they'll insert a tube, and they'll insert gas and contrast, and they will do a regular CAT scan on your belly.
So they're basically opening or blowing up your colon, if you will,
Distending your colon.
Right.
Exactly.
That sounds like that might be a bit painful, though.
There is crampiness with it.
Yeah.
Usually no sedation with that test. So it's the same crampy pain you'd experience with a colonoscopy when the surgeon or the gastroenterologist is insufflating air into your colon.
Right.
And then those pictures are taken and read by a radiologist. And that's labor intensive, it's hard. But the quality of it is pretty good. It's probably a close second to colonoscopy. Of course, there are some weaknesses with it.
Oh, sure.
One is, if you have a flat polyp, it's not going to see it very well. If you have small polyps, it tends to miss those. So the accuracy of a virtual colonoscopy for bigger lesions is probably close to equivalent to a colonoscopy. But as you get to lesions that are 1 centimeter and smaller, it's going to begin to get worse than colonoscopy. And flat lesions, it's going to miss.
And then I guess if you do find a polyp, you've got to go through the whole process again to have it removed, right?
That is correct.
Yeah.
Now, we do have a relationship with some of the radiology suites around town, so that if they do a virtual colonoscopy and they find something, they'll send the patient right over to our office, and we can then do the colonoscopy and prevent another bowel prep, which is the most miserable part.
Exactly. And I guess the least and the most private, it would be the at-home
yeah, let's talk about that. Cologuard. It's a hot topic now. You see it commercials on TV quite a bit. It's a test that measures two things. It measures hemoglobin in the stool and measures DNA fragments that are sloughed off by the cells in your colon. So it is measuring for the presence of DNA that may be present in a polyp or a cancer. And so you do this in the privacy of your own home, you send it off, and then you get a reading back either as positive or negative. And the question is, what's the accuracy or the efficacy of this test? And they claim that about 92% of cancers are going to be picked up this way. So at first thought, that sounds pretty good, but that's a cancer. And I would hope that it could pick up a cancer.
That, exactly. We want to prevent
yeah,
having that.
There you go.
Exactly.
There's the crux of the matter, is that if you want a screening test, you want to pick it up before it's a cancer. So when you start looking at those tests' ability to detect a polyp, the accuracy drops off rapidly. They quote 42% or so detection of precancerous polyps. And that's where you want to pick up something. So what's the, but still it's better than nothing.
Exactly, yes.
So how do you decide which one to do?
Right.
The gold standard is still colonoscopy. I think it's the most accurate, going to pick up the highest amount of polyps and can be therapeutic at the same time. In other words, you get the polyp and you get it out at that time, and then you're done. It's recommended you get a colonoscopy for an average risk person every 10 years. For virtual colonoscopy, they recommend getting that every 5 years. Cologuard testing, first of all, Cologuard testing is not appropriate if you have a family history of colon cancer, if you have rectal bleeding, or you have other issues. It's for the average risk person. But they recommend doing that at 50 and starting every 3 years. So let's look at the cost of each one of these then. A Cologuard test is actually not cheap. It's about $650.
Oh, wow.
So you talk about doing that 3 times in 10 years and you've spent $1,800 or more. Of course, for screening, insurance will pay for this, but these are the costs of these tests. Virtual colonoscopy, somewhere around $500. So if you have to get one every 5 years, that's $1,000 over 10 years. And colonoscopy, a high-quality screening colonoscopy, somewhere between $1,200 and $1,500 if it's done in an outpatient setting, you know, around town. That's going to be where you're going to get your best price, probably.
Talk about your facility a little bit.
Yes, we are ASGE certified. So that basically means getting to some of the quality things we were talking about earlier, that we have put our data out there. We've had to collect our data for withdrawal rates, for adenoma detection rates of each of our physicians, to document quality and have that independently reviewed by a third party, in this case, American Society of Gastroenterology. And that gives us a certification that basically is saying by an outside entity that we are doing a quality exam. So when you see that seal on our center, a patient can be assured that they're going to get a quality test. I'm not sure what other centers around town have that yet, but I know that it is a hot topic, one that people would want to have.
Sure.
And that's what makes, one thing that makes our center a little bit unique. The other thing that makes it unique is cost. We're a physician-owned practice. We're able to control costs quite stringently all through the process because we're vertically integrated. We handle everything from the beginning to the end.
Gotcha.
So we hopefully can keep costs down and also have a pleasant patient experience because we know everybody.
Right.
I think those are the primary things that make us different than going to a hospital or another facility.
Have you ever seen an instance where once you go in and you're doing a colonoscopy that you find issues and then do you have to transport people to the hospital or what kind of, happens if you go in and you're like, oh my gosh, this is a lot more than what we bargained for?
Well, I think perhaps in that setting, what we're really talking about is what's the chance of perforating a colon?
Right.
Because that's, or causing harm to a patient with a colonoscopy. That's a real possibility, but it's a real rare possibility. Maybe 1 in 10,000 cases would end up with a hole in the colon from a colonoscopy. It's been reported in the literature. That's about the risk rate. We're around that. It does happen rarely. If that happens, it's an emergency. There is no doubt about it. A patient would need to go to the hospital right away, and we would need to make arrangements for that. And being a surgeon myself, or with one of the surgeons in our group, we would take care of that very quickly.
I was going to say you would be the same physician to
Yes.
fix it, if you will.
Yes.
Would it surgically be fixed, or it wouldn't be a removal of the colon part, would it?
Well, oftentimes there's something wrong with the colon, with that section that had a hole. So we were talking a little earlier maybe about diverticular disease.
Exactly.
You could have a perforated diverticulum, in which case, we might have to remove that section of the bowel. And they're all ready bowel prepped. They're ready for surgery. We just go ahead and do it.
Let's talk a little bit about that. What is diverticulitis and
Diverticulosis.
diverticulosis? Because there's two different.
Diverticulosis is something that's an acquired problem of the colon as we get older. There are little out pouches that develop on the colon. I roughly say that the incidence of it is about what your age is. So if you're 50, you're going to have a 50% of the population are going to have diverticulosis. But of all the people who have diverticulosis, only about 10% ever develop diverticulitis, which is an inflammatory condition where one of those little out pouches ruptures and spills a little stool into the belly, which is very irritating and causes immediate, pain and fever, and has to be addressed. Usually stops a patient right in their tracks.
Okay.
And so the 10% of patients who get this, who have diverticulitis, we manage with antibiotics usually as a first-line therapy. Surgery is going to be second-line therapy for those individuals who either just don't get better or who are getting worse quickly.
Right. Is this something that will heal itself, or and kind of subside for a while and then maybe rear itself again, or is this something you just live with the rest of your life?
Yeah, well, if you look at a person who gets one episode of diverticulitis, we usually manage that with antibiotics. And I tell them you've got about a 50% chance to have a recurrent infection. And if you are going along and you don't have any problems, we don't need to see you. If you continue to get bout after bout after bout of diverticulitis, at some point it becomes burdensome to the patient. They're always thinking about it. They never know if they can go on vacation, if they're going to have a problem. Are they going to have access to a doctor to get antibiotics? Are they going to end up in the emergency room with a perforated colon? If you get to the point where it's always causing a problem, then yes, surgery becomes a definite answer to this problem, because it takes away the symptoms and gives the patient their life back. They don't have to worry about when they're going to get their next attack.
But that's not cancer. So let's talk a little bit about colon cancer. some of the warning signs besides, you know, what you find from a colonoscopy? What are some of the other signs that you might?
Yeah, there's a real problem because colon cancer they call a silent killer. Yeah, just much like hypertension or high cholesterol. When you think about these things, they're all silent killers to us. Colon cancer doesn't develop overnight and kill you the next day. It develops over a course of years as a polyp that ultimately becomes a cancer.
Right.
So when you're talking about symptoms, when you see symptoms from colon cancer, you're going to be pretty late in the game.
Right.
Things like changes in bowel habits or rectal bleeding intermittently, weight loss, loss of appetite, abdominal bloating, those sorts of things always warrant a workup.
Right. And in the event that colon cancer is detected, what would be the treatment plan for that?
There's another full question.
Yeah.
That's a big discussion with a patient. For me, that's like a half-hour discussion in the office with a patient about how to work that up.
Right.
We want to know whether that disease has spread anywhere.
Yeah.
So that usually means a lot of testing in terms of CAT scans and chest x-rays and blood work. Once we've done all that, and if we find that the cancer is localized,
Yes.
then surgery's the answer. If we find that the cancer has spread to other places, and the common places for colon cancer to spread are the liver and the lung, then we will maybe start along different lines, maybe using chemotherapy first. And usually these cases are presented in a multidisciplinary clinic where we're sitting with radiologists and radiation oncologists and oncologists, social workers, and we present the case and then come up with a whole treatment plan for the patient.
So the easiest thing to do is to pick up the phone or either go on your website and get that colonoscopy done and done today, right?
That is the right answer.
Doctor, thank you so very much. And thank you so much for joining us. Remember, for more information on colon health or to schedule an appointment, check out their website. That's csgaky.com or give them a call, 859-278-8486. Thanks as always for watching this and all of the LEX18 digital conversations. For more digital conversations, just log on to our website, lex18.com. Until next time, I'm Davidson.